I see it is now. Thank you very much.
Sorry about that. Okay. We also have all the quality control data. Everything is right at your fingertips. Once the visit is complete, we generate a full compliant report, and that full compliant report hits over 350 data points, and you'll see an example of that. We also will insert that into their EHR, and depending upon their system, if it's a hospital system or et cetera, we have other ways of integrating. And then we do this every year. We'll repeat it next year, and you'll see why that information is valuable. As you see here, when we contact that patient initially, we are the caller, which is another senior, is explaining to them that this is a free visit. There is no deductible. This is what Medicare, you qualify for. This is what Medicare wants you to do. And we're going to be screening for way above what a normal physical does. Like, one of the key concerns of a senior is their vision, their eyesight. And a lot of them have had peers that have had lost their vision because of macular degeneration. So we talk about how we do a screening in there for that as well. So we're looking at over 350 plus data points, everything from cognitive to, diabetes, dizziness, fall, depression, to medication reconciliation, and everything in between. At the completion of the exam, we have certain triggers that can be customized for what you would want in your clinic or hospital or ACO. We have our standard ones, which are pretty detailed, but they could be also customized as well. One of them, obviously, is the chronic care management of patients that have 2 or more chronic conditions lasting for 12 months or longer, okay? Then there's mild cognitive impairment risk, depression screening, other diagnostic testing. All of these are triggered throughout, and we give the correct ICD-10 code to give the medical necessity for follow-up on that trigger, what's been clinically triggered. The MA, or the certified medical assistant, or the licensed medical personnel that is conducting this, it does not need to be the physician or the nurse practitioner or PA. It doesn't need to be mid-level. Okay, we have a very specific guidance from Medicare on this. They've been involved with us on this program since its inception. What happens is at the completion of the exam, there are what we call, action results that need focus relatively quickly, i.e., the last time the patient visited, that the patient is not taking their medications properly, that they are struggling with depression. Those are issues that will be addressed, and the office will be immediately notified while the patient is still there, that an action plan can be taken to schedule an immediate follow-up visit, along with other ICD-10 codes, cardiovascular risk, and treatment options. So if you're in a multi-specialty clinic, it can generate out the referral for the cardiologist, for the endocrinologist, for blood work, for a CAT scan, etc. All of those things are triggered out here. The reports, we're able to look at all of these different types of reports, everything from the risk matrix going down to trending report on waist size, smoking, non-smoking, alcohol. You're able to literally click and customize any report to see what your patient population looks like. So if we look at a risk matrix here, it shows the risk factors down the left side, and we'll go down to cognitive process. And then it rates them low, moderate, high, and severe. As you can see, severe is highlighted. So if this was an actual live screen, I would click on that. And by clicking on it, it automatically brings up those patients and the patients there of where they rate in their relative value, as well as if I was to click on, and I'm not able to because this is not live, this is stagnant, but if I was to click on Joe William, I could click on Joe William and see this year's annual wellness visit compared to last year's information and see where that patient is trending.
Hey, Mark, are those based on are these validate, when you talk about the test results and then the relative values, besides using a patient as their own control, is this test validated as compared to norms? Is this tapping into some database and the individual tests themselves are comparing to norms to get the test results as a relative value?
Yes, actually.
Hey Mark, I was going to say, yeah, can I answer that? Yes, absolutely, because what happens, this particular test and software platform has been around since 2011. So it captures all of that data from all of the other populations that have had an annual wellness visit, and it scores against what's already been populated into the data portal as a whole.
But is that when you say all the other patients, is that all the other patients
not just unique to that clinic? It would be within that whole system itself for any clinic. It'll look at it across the board.
Any clinic anywhere in the country? Any
clinic anywhere that has utilized this software, yes. It will check it again.
And how big? Okay, so that was my next question. So, I mean, you know, I have no reference point as to how many clinics use the software, which would somehow lead you to give some predictability of statistical significance, right? Based on, you know, if there were only 4 clinics in the last 6 years, right? Those norms.
Well, here's an example. I mean, hospital associations have endorsed. There's hospital systems that are already utilizing, you know, the software itself. One that I can think of is Jefferson, and they have about 750,000 going through.
Okay, that's all I had to hear.
Wellness visit. Yeah.
Perfect. Thank you very much.
Yes.
Okay.
And you'll see it. You'll see it in a couple of additional slides as well. You'll answer your own question too, but thank you for asking that and Dana addressing it. Again, appropriate follow-up care. And this all goes to, again, addressing the patient where they're at, their needs, okay? The nice thing is what people don't realize, what a lot of clinics and practices don't realize is that when Medicare gives you money, they have a lot of requirements, right? Everybody knows that. But what part of that is having all of this detail. There's a reason why we touch over 350 data points, is having a report that needs to be in a certain format that is given to the patient and is in the patient's EHR, okay? And so this is a sample of what a report might look like. Everything from the risk factors for that particular patient, where they fall into as far as rating and the level, any treatment options, etc. We also, very important, is a 5-year written plan, okay? To give you an example, we have been documented by Medicare through a practice that was audited, and they reviewed this, and they said that literally this was the best annual wellness program and visit and reports they had ever seen. In fact, that's why we offer a guarantee it will pass any Medicare audit. Okay. Personal health care advice, we address weight loss and nutrition. These are all requirements that need to be included in this report. And often, if someone tries to attempt all of this on their own, they're not getting all of this information. So it leaves them vulnerable in the event of an audit, or and it also takes them 2 to 3 times longer to perform the annual wellness visit. So we're addressing those. This is what you were asking about. This dynamic data what you see here is you can slice that information for male to female patients. You can look over year smokers. This information to the right deals with what we call the universe, is what Dana was sharing, of all of the patients that are in the system. And then you can look at year over year, and then you can look at where do you stand as far as the universe goes, as far as risk factor, as far as compliance. Also, we can look at, you know, the race or ethnic background as well. This all lends to it. This is just a partial list of some of the hospitals and ACO systems that are utilizing our program, the WellCheck 1 program. Also, we are endorsed by multiple state hospital associations. In fact, the third one down, the Metro Chicago Healthcare Council, just merged and with the Illinois Hospital Association. So we now have that statewide in Illinois as well. You could say benefits for the hospital or practice. It's the same. Again, we're providing significant new revenues by capturing this. We're decreasing the cost of care by being proactive. We're increasing shared savings for hospital systems and ACOs, identifying critical risk factors and addressing those with the proper ICD-10 codes. We're enable them to modify any of their risks, because you know what to address and what not to address. Population health data speaks to the last couple of slides. And most importantly, what a lot of clinics want to know is, how does this change what we do? Well, because the whole system is encompassed and we have a turnkey system and program, we actually have over 70+%, in some cases as high as 80 and 85% capture rate of their Medicare patients participate in the program. And the way that we do this is it does not change the workflow for the physician or the mid-level, because of who is qualified to do this with the proper training and licensing, which we walk through. Onboarding is very straightforward as well. We can typically have an office once everything is in place, i.e. all the documentation is in place. This process takes about 30 days. We can have a clinic or a hospital up and running within 30 days with very little outlay at all, okay? We integrate with their EHR. We scrub the patient list, the qualified Medicare patients. So outside of 90 days, we can see who qualifies and who doesn't, and what patients qualify for their second year of their annual wellness visit, and we conduct that as well.
I'm sorry again to interrupt, but could I ask a stupid question? How does a hospital, I mean, I understand how a doctor bills for a patient for an annual wellness visit. When you say a hospital as a client, is the hospital actually able to tap into their database and bill? Because the hospital patients obviously have their own doctors in private, or whether they're employees or whether they're in private practice, but it's a different entity, right? They have a medical group, depending on the state.
Yeah, thank you for clarifying. Yes, it is the latter of what you described. Over the last, bunch of years, the hospitals have been acquiring many practices, many primary care practices, specialty clinics, et cetera. So the practice is technically owned by the hospital system. Okay.
Okay, so it's the medical practice that because obviously, yeah, a medical practice that could bill Medicare, right? Not a hospital is a different type of arena.
Correct.
Okay. And one last question, just so I don't forget. Has this been utilized in nursing homes under Part B? Like, do people still qualify? So once someone goes through that acute phase and they're in the home and they're on the Part B Medicare, is that something that it works in that arena?
Yes, yes, it would work in that arena. However, the physician would be selective on who would be appropriate to have an annual wellness visit. Now, when they're in rehab, obviously they could do it and go back to their primary care physician. But if they're in a long-term care situation, it would be up to the individual facility, and the physician would have to be on site while those visits are being performed.
Well, but that's okay. So that's what I'm getting at, though. I want to know what you say, but would have to be selective. So let's say I've got a friend up the block, and which I do, and he has a 300-bed facility, right? And they always want to do what's best for the patient, and at any given time, whatever, 80% are going to be in the Part B phase, right? So, if I went to the chief medical officer and said, hey, your medical group covers this, you're the medical director, and your medical group, your 4 docs cover this, you're rounding every day on the patients, right? Is there a reason why they couldn't say, fine, let's get the program and run it on the patients while they're in the long-term care facility setting?
They could very well do that, yes. They could run the annual wellness visit while they're there in that setting. It would just be a matter of scrubbing the list, so to speak, to make sure that the patient was eligible for an annual wellness visit, that they hadn't already received it for that calendar year.
But they're not, more than likely a good percentage if they're sitting for 2 years in a nursing home, unless these doctors, they're not going to be doing that. And being they want to pick up on all these things and give as good a care as possible, it seems like if any population, it would make sense. And to some degree, that population, you could keep going better. And is that on that? Make sense?
No, you're right. You're spot on. Yes, you're absolutely right.
Got you.
Now, the only thing that they can't do in that setting would be a chronic care management.
Right.
They can certainly do an annual wellness.
Yeah, and I'm just about to speak to that right now, actually. So thank you for clarifying. So we look at the identifying, and then we enroll. Obviously, we're going to be enrolling these patients into the annual wellness visit, and then we're scheduling them, we're bringing them in. Along with that, once that is complete, part of those triggers is identifying who is qualified for the chronic care management program. And at that point in time, that patient can be educated and enrolled as well. We have integrated care teams, complete care plans, et cetera, et cetera. We engage those patients in the required 20-minute non-face-to-face meetings monthly, along with all the documentation that is necessary. And then we provide all of that information to the practice. The practice then bills out at that point, and they pay us after they get reimbursed. So the nice thing is we're actually going in and we're performing all of these services prior to them having to, make a huge investment. On the chronic care management, let me touch base on this here. Again, the whole idea of the chronic care is to be proactive in these patients' lives. But what it allows a practice to do is to increase revenue. This is a challenge. I'm going to share this with you. As of October of last year, Medicare says that there are approximately 35 million plus patients that are qualified in Medicare for this program, and less than 100,000 patients actually are participating. That's less than 0.001%, okay, of patients that are qualified that can be enrolled. There's several obstacles for it. Number one, the practice sees it as a very cumbersome, and it's very not clear to them how and what they need to perform. So we have a turnkey solution. We can increase their revenue. We can allow higher quality patient interaction because we're constantly touching that patient and interacting with them in between visits, and we're doing it every month for a minimum of 20 minutes. We're improving quality of their care improving patient satisfaction because they feel like they're being taken care of and listened to, and we're reducing costs because it's a proactive measure. How do we do this? Well, we offer it in a cloud-based system. It's a turnkey service, a SaaS model, okay? We onboard the patients, typically that are triggered out through the annual wellness visit. We offer them 24/7 patient access. We perform the medication reconciliation and monitoring, and we track them daily or monthly, and we give them a summary. It's all comprehensive. We take all of their medical records and we put it in one place for that patient. We produce a summary for that PCP, that primary care physician. There's coordination with their home and their community partners, two-way sharing, et cetera, et cetera. And then more importantly, their caregivers. It's very important information to have at hand. How we do this.
Question: when you say that you are doing all of that, because I know we've done chronic care management in some of our clinics, and I know that it's been very taxing to the provider to have 24-hour access for the patients if they need it, and then the 20 minutes that has to be documented per month, of services being provided to that patient. Like, do you have certified nurses or doctors that are doing that, or how is that follow-up being done by you guys?
Excellent question. Yes, we actually have a clinical staff that is everything from a PharmD to nurses, et cetera, and all licensed and all qualified to interact with that patient and to help drive that patient and touch that patient on a monthly basis. You're absolutely right. Most clinics that would try this, it's physically almost impossible to do if you have any volume of patients. I mean, because think about it, it takes 20 minutes of non-face-to-face with that patient every month. So if you had 100 patients, how many full-time employees do you need to do this with 200 patients, 500 patients? It's next to impossible to do.
So then are we employing your staff so that we're not dealing with scar issues or fuse splitting issues based on the fact that, it has to be done by the provider that is rendering that care?
We actually are providing this care for the provider. We'll just call. We work with the provider and are providing it under their umbrella, and we also communicate with that practice all of the information that is vital in the constant in whether it's coordination of reconciliation of medications, all the way through coordination of care with referrals, et cetera. We have a staff that's all they do, and as a result, it's fully compliant, and as a result, the practices are being able to have that touch, that connection with their patient that is virtually impossible for them to do with all the other demands they have in their practice. Dana?
Do you have them licensed in the individual state of the provider?
Yes, every 50 state, in all 50 states.
Terrific. Okay.
And then do we get paid directly and then we pay you a fee for that, or how does all of that work?
Yes, you do. And in fact, and I'll show that in a second here. But in essence, to shortcut, after the 20 minutes has been reached for that patient, okay, we then send the reports, and we're always communicating with the practice that the 20 minutes has been reached on Susie Jones, and therefore now you're going to bill for that for this month, okay? And we know, because it has to be documented, we have a time clock on every interaction that happens with that patient. And we have what we call pods of caregivers that typically will work with, those patients. So that patient isn't being touched by 5 or 6 or 10 different people, but they're being worked with a team that they're comfortable with. Okay. So what we do is, yes, we reach out. We accumulate those 20 minutes and we're doing all the requirements. We're available 24/7. We explain the importance of any lab tests, medications, any consults, etc. We review all of that with the patient and review all of those, and then we monthly submit it to the provider. We also are looking at, again, the coordination of care and the case management of that patient. And once that patient has been triggered out at the 20 minutes, the clock starts again after, you know, in the following month. What we're looking at did I answer your question, I'm assuming, correct?
I'm just waiting on how it ends up getting reimbursed and billed and cost.
Say that again. I'm sorry. You were slightly mumbled on my side.
I mean, I was just waiting to hear how much is the revenue for it and how much does it cost.
Sure. Excellent. Actually, I have an ROI we're going to look at right now, and that will answer your questions. Okay. So let's look at this real quick. Let's look at first the annual wellness visit. It's simple, 2-page. Let me walk through this. This is looking at Arizona, for an example. The state reimbursement for the annual wellness visit is approximately $172, $172.03. What we know is over a 4-year history that we can capture at least 70% and sometimes even greater, as high as 85%, or even knocking slightly north of that. But let's just base it off a 70% capture rate. We're looking at approximately, in this example, 6 providers in a clinic, and we know, based on information and history, that approximately 500 Medicare patients per provider. So that's 3,000 Medicare patients. Based on that, we then know that 60% of those patients, those Medicare patients, have significant risk factors, okay, i.e., chronic conditions. It's actually it's closer to 2/3, a few percentage points higher, but we'll use this as an example. This is what's also very interesting. Because the annual wellness visit is very proactive, we know that we are able to identify in those patients, those existing patients in a practice, 2 additional risk factors just by going through the annual wellness visit. And those 2 additional risk factors, each risk factor generates at least 2 additional follow-ups that year per risk factor. We know in a clinic setting, it's an average of about $95 is the average income that is generated from each of those follow-ups. In a hospital setting, i.e., hospital owns a clinic, and they have their own labs, their own diagnostic equipment, their own specialty specialists that are affiliated with the system, or a multi-specialty group. That reimbursement is closer to $295, we have found. So if we look at those 3,000 patients, we know that we're capturing 70% of them. So 30% we're not capturing. That leaves us approximately 2,100 patients we're able to capture in the annual wellness visit. Based on the reimbursements for that state, it's over $361,000. Yes, we get paid for what we do. So what we get paid, minus out the fees for our whole system and et cetera, the whole marketing, driving those patients in from the 15% or less compliant capture rate to over 70, okay, that practice then will net over $224,000 their first year.
So basically you're charging $65 an annual wellness visit test?
Approximately, yes. Approximately. It's going to depend on their volume, okay? And that is to do everything, to drive that business in. Now, additionally, though, we know that because of our system with the clinical triggers, we're looking at about another 1,260 risk factors that are identified through our program. And again, we have this based on a 4-year history, which each of those triggers 2 follow-up visits a year. And if you take into account all the triggers, you're looking at an additional $957,000 plus just from the triggers that we generate from our program. And you add the 2 together, the annual wellness, along with the triggers, it's close to $1.2 million, 1.182. And that's based on providers with only 2,100 patients that are enrolled in the program.
And out of that money, how much do you determine to be provider time, like practice provider time, versus, because obviously your program comes with, personnel, software, et cetera, systems, but, does this factor in whatever staffing costs are necessary on the provider side?
Excellent question. This particular example, it does not. And the reason why it doesn't, it depends on how they want to participate. The top half, where it says the profit calculator on the annual wellness visit, that could be determined by if we provide a staff person, if they meet that trigger, those qualified patients, or they provide a trigger. If they choose to run it on their own and we train their staff, the person that is qualified to do this and Dana can provide this information to you, literally is a licensed certified medical assistant that when we put this program together, what we have found is that we can perform, because of our system and the software and the marketing of getting those patients in the door, we can approximately do between 12 and 16 patients in a day. What the office needs to set aside for us is a patient practice room. You need to say, you can have room 1 and you can have it on Monday, Tuesday, and Thursday from 8 a.m. to 5 p.m. And over at this practice here, you could be there on Wednesday and Friday from this time to this time. They need to set aside the space for us to perform it. Okay. The bottom portion might answer both of your questions as well. And that is additional revenue that is generated, the 957, on the additional follow-up outside of the annual wellness visit. That would be as they were normally seeing patients.
Okay. Got it.
Except these are, again, we know we're able to, these are not being captured now. Typically, we already know that. In 4 years, we know we're able to identify these additional ones on top of what you're already doing. So that would be normal staff time, normal appointment. So not only are you capturing the AWV visit, then you're capturing the follow-up visits, which falls into your normal schedule and your normal staff. Okay? Did I answer your question?
And again, on this, Mark, they don't pay. Well, they don't pay us until they're paid on. Is that how the wellness side works, or just the chronic care management?
On both, exactly. We submit all the completed annual wellness visits that are done on the patients. Okay, after they're completed, they bill out. The clinic bills out, and they reimburse us, or they pay us. We invoice them after they are reimbursed. We know with a 4-year history that these clinics, number one, they do pay, believe it or not. We have an extremely high success rate. Number two, those clinics, they're happy because this is found money. I mean, this is found money, and it's better patient care. So yes, they don't pay us until they get paid. Let me click on the CCM because that's going to show you something slightly different. Okay, and again, these are the numbers that we're going to look at here, it's all going to depend on volume, number of patients. But if you look at on the chronic care management side, the average in I believe in Arizona is $42 per patient per month. And there's a lot of strings and requirements that go towards billing that code, as you were indicating earlier, not to mention the time. It's very cumbersome. So we're doing the non-face-to-face patient interactions, the 24/7 availability, all the reports, the medication reconciliation, et cetera, et cetera, et cetera, et cetera. And we have a flow chart that we can show you what the practice responsibility is and what our responsibility is. And I think that'll put a smile on your face. And we could share that with you as well. But this is looking at 6 providers. And again, this is based on information that we know, okay? We know that we're going to trigger out a certain percentage of those patients, 2,500 patients. We know that we're going to trigger out 1,875 of those. And if we only capture 70% of those, or 1,250 patients out of the total number of patients, what we do is, again, we complete all the requirements. We have the full staff to do it. And then we're communicating with the practice. And then we say, you can now bill this code for these patients. You bill it out. And once you bill it out, then you pay us after you are reimbursed. Okay? The reimbursement, let's say you were to net, and again, this depends on volume, and it helps to see the flow of whose responsibility is who's doing what. You're looking at a $19 net, okay, in this case. And so that monthly revenue for those patients is $2,350, which is over $285,000 that is not being claimed today. We know that. So,
Dr. Jarvini, do you have any comments on that? Because I know you were trying to do this in your practice, and when we met last time, you said this was one of the most complicated ones to get reimbursed on.
It is really complicated. What we're running into is that the 20 minutes is the goal, but a lot of times patients you've already hit your 20 minutes. Sometimes we have patients exceeding over 100 minutes of calls that month because they have other concerns that add on, which when you have maybe 1 or 2 certified MAs working the phones, you have problems trying to capture 20 minutes for separate patients.
yes. And you hit the nail on the head, because often what we have found is actually, and again, in doing this program, actually we found that our number is close to 26 to 27 minutes on an average. Because you're going to have the outliers that are going to run a lot longer because they want to talk to somebody. Somebody's calling them. Somebody's talking to them about their, and I know, I had, an older parent, it's nice to get a phone call and it's nice to communicate with somebody. The goal is 20 minutes, but it exceeds that.
Mark, can you show that flow sheet of what we do versus what the practice has to do?
Yes, give me a second here.
Well, let's get the finishing up answer to this question, because you see that problem that he's having on the ground with this. So how does this help solve that?
Sure. Okay. So if you look at this flow over here. Okay, here's the workflow. What we do is we identify who's qualified, okay? And we could do this a couple of different ways. Obviously, one is through the annual wellness visit, but we also could work with the practice of helping identify what patients have 2 or more chronic conditions as well. We've got several programs that this could work for. once those patients are identified, we can utilize the annual wellness visit as that springboard to enroll those patients, because that is one of the Medicare triggers that Medicare allows the CCM be triggered out through their annual wellness visit. The nice thing about our program, we found, and we're the only ones that offer this, we have our own certified EMR system. So as a result, what we have found is we would like to think all practices have a compliant EMR, but the reality is a lot of them don't, okay? And if they don't, then they're automatically disqualified for participating in this program. However, that is not true with our program, because we actually provide all of this care within our certified EMR. That is a requirement from Medicare. So every practice is available to us. So once we do that, then you look to the right, we're downloading that Medicare list. We're doing the CMA is doing the AWV. They're evaluating and onboarding that patient into the chronic care program. Then what we do is we develop a plan, a chronic care plan for that patient with physician oversight as well, because the physician that practice can review that information and make any updates as needed. It's CMF's certified EMR, as I shared. We have the 24/7 care team available, and we provide a care plan to that patient. Obviously, it's in conjunction with their PCP. We have all the licensed medical professionals that are qualified under the CCM. We're providing that 20 minutes of care and tracking it. We're doing the monthly patient outreach for that. And this is the nice thing that you mentioned. If they go over the 20 minutes or 25 minutes or longer, that's our responsibility. Unfortunately, it doesn't roll over to next month, as you know. It's only for this month. But by us taking this responsibility, we are responsible for that. So that therefore gives you a fixed cost. We do all the data transparency. All the information is time stamped. It's all seamless. It can go into an EMR, depending upon what your EMR looks like. We can provide that. We provide the whole billing statement. We produce it. We shoot it over to the practice. We then give you ample time to go ahead and bill out to that patient. We can do credits for patients that were ineligible, and then the practice bills out for that, and they do the preventive care and the ancillary services. So the green are your responsibilities. The purple are what we are responsible for. And as a result, we give you a fixed cost per month per patient. So when you're billing out that $42, you know, no matter what happened, number one, it's compliant. Number two, it met all of the requirements for the time stamping. And if there are run over times, you're not eating that cost. We are.
What about a gain in cost? Because I know in Arizona here, they are also offering a higher reimbursement for greater than 20 minutes.
I have not seen that.
I don't have information on that either. Is it billed under the 99490, or is there another code?
I believe so. I don't have the exact codes that our billing company, but we have received.
Interesting. Would love to.
There's higher reimbursements on those same types of services once someone has been released from the hospital. That first 30 days, there's some aftercare, and the reimbursement's higher than a regular chronic care 20 minutes. But
no, it's not that one. It's
not that. Okay.
Yeah, that's the transitional care codes.
Transitional. There you go.
Yeah.
Well, maybe you could get that
moment. Good.
Maybe you could get that information to them, and they could vet that out. That would be good.
Sure.
Yes.
Yeah.
So then what would be the cost for the chronic care management? I mean, if we're getting the, I think, $42 or something like that, what is the cost for what you guys are doing?
Again, it depends on the volume of patients. Typically, you're looking at about $23 a patient. So your net, if you look at the ROI that I have up there, netting $19 a patient, and you saw how we laid out the responsibility and the workload. You're netting $19 per patient per month. So if you're looking at this scenario here that I laid out on the assumptions, you're looking at over $285,000 annually for those patients.
And on that one, Mark, it sounds really like the practice is not incurring much manpower, hours, et cetera. On the chronic care management, I mean, the work is really all done within your program, both within the software, follow-ups, et cetera, right?
Exactly. Exactly. And that speaks to what I shared in the very beginning. Literally, Medicare knows that this is an important program, but just like anything else, it is daunting to comply with all of the requirements. And as a result, less than 0.001% participation. And the nice thing is we, in fact, I want to show you something here.
And Stephanie and John, you could comment on this, having done it, on site, but this seems like one of those things to me that a doctor's gut reaction may be initially, well, there's no way I'd give away 23 out of my $42, but once you've done it and it comes down to it, you realize that you'd rather take $19 almost for free and give the good care to the patient. Because unless you're able to scale this in an enormous volume and build the infrastructure around it, it's not necessarily very practical to do in a regular practice without this type of system. Would that be your take, John?
I totally agree. And the biggest bottleneck, I think, in a practice, if they're doing it themselves, really is capturing those patients. We have over 4,000 Medicare recipients within our two practices. And having two certified MAs calling as many as they can, you still don't get enough time to capture all of it.
Not at all.
And how much did those MAs cost you, Dr. Jaravina, if you had to put a yearly salary on them specifically to capturing those patients?
Well, we're hiring them at maybe about $30,000 a year.
So $60,000.
Yeah.
In Arizona.
What are they capturing?
What are they capturing?
Out of those 4,000.
Out of those 4,000, one of our clinics did about 800, or maybe 600, and the other one is about 300. And we have a kind of strange situation in Arizona because a lot of our patients are winter visitors, and so that 4,000 attributed lives to us is really not all there, but we could capture them still.
Exactly.
You just have to time it when they're in town. The snowbirds, you just have to, spend more time doing it in the winter, right? As opposed to
exactly. That was going to ask the next question is, what if you do have a winter visitor and they're in this program with you? How does that work? Does it just end once they leave the state, or just follow them to their home if they're not in another program in their hometown?
Well, number one, they can't be in another program because it is very similar to what you're describing. It's a land grab, okay? So you want to capture that patient. Once you have captured that patient and they are enrolled, and as long as they are participating and choose to continue to participate in the program with you, it doesn't matter if they're in Chicago or they're in Phoenix, because the way, correct, Dana?
Right, because it's a non-face-to-face.
Exactly. So what I was, so you've actually done an excellent job in what you described to me, but even at that, you're capturing about less than 25% of those patients. Okay.
Yeah.
So what if we can, and they have to do it every month. It's not like, oh, we captured them. Okay, we can move on. Now we've got this annuity every month. They have to do that same workload each and every month. So what if we could capture 60 to 70% of those patients, and we take the responsibility of all the documentation, the reports, et cetera, and the staff time? Would that make it more appealing or more workable?
Very attractive, yeah.
Much more attractive.
I can tell you also in Florida, what we've had to do is actually have the patient sign a contract that they agree and understand that they're under chronic care management at our facility, so that when they do go, because a lot of them are snowbirds as well, that they're not just leaving and then starting that up with another provider, because it does become a problem and you get denied, and then you've done a lot of work without capturing that revenue. So we're trying to make sure that they're clear under contracts and they understand that.
Exactly.
Good. Yeah.
One last question: does this apply? How does Medicaid, or we have Medi-Cal here in California? Do they pay for any of this?
Infrequently. It depends on the provider.
That's funny. So it's a government policy to
right.
provide these codes. Say we want to keep the population healthy, but we'll take care of the old, not the poor. That's an interesting one,
right.
Which would be
but
a
if
much
you're old
more.
And poor, yeah. Well, actually, on the annual wellness, it does. They can be dual eligible. They can be a Medi, and get their annual wellness visit done without concern. It's on the chronic care side that there's a concern, because what we find with a lot of the Medicaid that there's a lot of HMO. That
Sure.
to be,
Exactly.
in a plan, and the plan has to be contracted to be able to, reimburse. So.
But you said on the wellness. So you're saying on the wellness, then most of the Medicaid now does have coverage through the various plans?
Yes, they do.
Okay, great. So that would be a target as well.
Mm-hmm.
Thank you.
Well, I would like to just kind of finish up here, if I could. I'm not exactly sure of everybody's involvement here outside of what I've been gathering. So with that, Joe, I'm going to hand it off to you, so that could you unmute and jump in there? Hopefully you're still on. You're here, Joe?
Yeah, I'm here. Thank you.
Hey Joe, if I may, since I have Dr. Jarvina and Higashi's both on the phone, both who've played with these within their practice, so to speak, could I just see if they have any further questions or comments before you round it up a little?
Yes, absolutely. Please do.
So one question I just had is I'm sure you've worked with a lot of places, so you're super, super compliant with everything, but do you have anything from attorneys that states that having you guys do the work, but us billing it under our providers doing the chronic care management, are you providing staff to be able to do the annual wellness visit, et cetera, that it's not violating any kickback or Stark? Do you have anything like that so we can take that to our healthcare attorney?
There is
Joe, I don't know.
Yeah, there is a document from our vendor that we could supply for the annual wellness side of things, yes.
And what about the chronic care management?
The chronic care, I will look into that and see if that's something that they can provide. Mm-hmm.
Yes, and how it works is we become an extension of your practice. We actually become an extension of your practice, and so that's why it's a very close relationship. So yes, we're going to dot the T's and cross the I's, so that everybody is compliant, and you are very comfortable with that, and so is your advisors.
Yeah,
Great.
It's been looked at many times. And the agreement do just what Mark said. So, of course, you pass it through your attorneys anyhow, but you give them that, and they go through it, and you're good to go.
Mm-hmm.
Great.
what we'd like to do is obviously, we'll get you the information that you need, that you were just requesting, and I'm assuming, Anthony, this is going to be coordinated through yourself, correct?
Yeah, sure.
Okay.
I got one more question.
Sure.
Regarding the annual wellness, is this just for strict Medicare patients, or is it also applied to Medicare and MA programs, any Advantage programs?
Dana?
Yeah, Medicare and Medicare Advantage, traditional,
Okay.
A and B, and then of course the Medicare Advantage as well.
And your algorithm here, or basically the 360 that you guys do, will satisfy all the MA requirements too, right? Because every MA program has separate requirements, but in general, if they're, detailed enough, it should satisfy majority of these MA programs.
Probably exceeds them, yes.
Okay.
I have a
We also
question
do.
for the two practices that are performing the chronic care now. How do you go about collecting the 20% if there is a deductible for that Medicare patient for that $42? How are you going about collecting that?
For us in Florida, I don't know how they're doing that. I think that they send out a statement. I think they actually send out a statement regularly to them.
Same here. We do have a billing company, and they send a statement to the patients, and we tell them it's usually a maximum for our state. It's a maximum of $8 a month if the service is used.
Okay, excellent. And the reality is what we have found is that a majority of these patients that are, and again, I think it's going to be regional, of what this is most of these patients do have some sort of Medicare Advantage program, which picks up that. So in essence, to a majority of these patients, there's almost a zero cost involved.
Okay.
Well, thank you.
One last quick question. As far as the electronic system that you have, is it just you will integrate with ours, or we have to utilize yours for the compliance of it, and then the billing and everything like that?
Dana, are you there? Yeah, I'm sorry.
What was the question?
So I noticed that you had said that you guys have your own electronic health record system to be in compliance in case an office doesn't have their own. If an office already has their own, my first question is, can you integrate all of your measures and data and reports into our existing electronic health records? And then my follow-up question is also then, are you guys entering in and doing all of the billing and coding for that, or is that something we have to do?
Two parts on the first portion, to integrate with your current EMR. On the annual wellness side of things, depending on the size of the system, there can be integration that happens. If that doesn't happen, then of course we provide a continuity of care document, so you can batch import that data into your EHR and drop into your individual records. On the chronic care management side of things, it does fully integrate with the EMR systems.
Okay, Trish.
As far as the coding,
yeah.
And as far as the coding and the billing goes, we provide a statement every month for the annual wellness visit with the codes, whether it was a GO438 or GO439, whichever annual wellness, whether it was the first or subsequent visits, so you know exactly what patient to bill for those. And the same thing with the chronic care management. We'll provide a monthly report of every patient that we have met the 20 minutes non-face-to-face that has been documented that you can bill for.
And if we're
any
using your
problem-focused or follow-up care would be, I'm sorry?
If we're using your electronic health record system, like you're entering in the billing and sending the billing out, or we're having to do that?
You're doing your billing. You're doing your own billing.
Okay.
So do we have to do all the G codes for all the metrics, for all the measures?
I'm sorry, say that again.
Yeah, you're billing for the annual wellness, which is the GO438 or GO439.
Yeah, but you know, in some of the patients, if they do have like an A1C, you want to attribute to an A1C less than 7 or less than 7, and then you have to give them a G code. That way they can you can upload that G code to CMS. Do we do that, or is that also
that is
provided by
something that you would do on your end? Yes. And the problem focused, follow-up care, you would be billing and coding those as well.
Okay.
But we provide the the medical necessities, the background work for you to be able to do that. The evidence that it's been performed on that patient.
All right.
Again, the billing responsibility, because Medicare only allows you to, through one lockbox, et cetera. And so you're doing the billing, your EIN number, et cetera.
Very good. Any other questions?
I think that's it, so I'm going to jump off, but thank you so much. And then Dr. Sennell, you can talk to me about it a bit later.
Thanks, Steph, and thanks, Joe. If you have no more questions, Dr. Javina, another Jonathan, are you good? And we'll just circle up with you after?
Yeah, sounds good.
Okay,
Great.
thank you very much. Hey, thank you all. Hey, Mark, everyone, I really appreciate it, and we look forward to working together. Thanks.
Thank you.
Thank you very much.
Thank you again. Take care.
Bye.